Here with me are Lindy Keller from BDAS, Regina Flynn from BDAS, Dan Audress and Peter Ames from the Foundation for Healthy Communities, and Brannon, and I might be forgetting someone, I'm sorry. But that's our planning team. So we're happy to welcome you here today. This is our first remote community of practice, as I think most of you are aware. So thank you for your patience as we figure a lot of different things out. Hannah will be screen sharing for me. So she has the slides. So I'm going to ask her to move to the next slide, please. So what we're doing here at our community of practice is working to support each other for the successful implementation of an integrated MAT approach. Of course, you know, today we are focusing this meeting on COVID-19 and discussing changes to MAT practices as it relates to COVID-19. Before we get started, I'm going to give a few announcements. Presenters now should all be able to mute and unmute themselves. Please do that when it's your turn to speak. If you are on the phone and I wasn't able to identify who you are before the meeting got started, please do send me an email so that we can track that for attendance, and then we need that attendance in order to give you your continuing education credit. If you have questions with IT, if you're struggling, if you can't hear me now while I'm speaking, please chat Hannah Lessels on the chat specifically. She will be able to help you. And then also, if you have questions, please make sure that those chats are addressed to everyone. We are going to be saving the chat at the end to make sure that we capture all of the questions following the meeting, and we are only able to save the chats that are sent to everyone. So please make sure you send your chats to everyone. I wanted to let everyone know that we do have someone joining us on the Zoom today that is from New Hampshire Public Broadcasting Company, from New Hampshire PBS, that is working on some articles about SUD treatment in the time of COVID-19. He will not disclose participant names or anything that he hears. He will not be quoting anything he hears today, but just wanted you to know that he is here with us today. And so, yeah, I think I will get going. Hannah, could you please advance to the next slide? So I want to go over a couple of resources that we have, which we will talk about again at the conclusion of the meeting. You all should be members of the MAT Google group. If you're not, please reach out to me and I can add you. We've been sending a lot of information, especially related to COVID-19 lately. It's been a very active group. So please feel free to share resources there, or also pose questions. Don't forget that as we're all navigating a really new and confusing changing time, if there are questions related to anything at your MAT practices, please feel free to share those over the Google group so that we're able to connect with each other in that way. We also have additional COVID-19 resources and our typical MAT resources available on the Center for Excellence website. We can disseminate those into the chat, the links to those as the meeting gets going. And then, as always, the center is still here for technical assistance. We want to be sure that everyone knows that while you have a lot on your plates, we are still here to help you however we can be helpful. Whether that be, you know, talking something through, or even helping you figure out Zoom. I know I haven't been the greatest example today because I am using a feature that I'm not typically familiar with, but we do have a fairly good handle on Zoom. So if you have questions about anything during this time, we're happy to help you. Hannah, the next slide, please. I'm going to go over the objectives for today's meeting. So we hope that by the end of today's meeting, you will be able to identify relevant federal guidance and regulations related to delivering MAT services during the COVID-19 pandemic. Also identify the relevant New Hampshire policies and regulations related to delivering MAT during the pandemic. And then also discuss emerging knowledge and promising practices for delivering MAT via telemedicine, which I'm sure a lot of you are trying to figure out right now. So we have two great practices that have some good experience using telemedicine to provide MAT services that are going to give us some information. Next slide, please, Hannah. My last kind of housekeeping item is about the questions. So time for questions today is going to be limited for the first hour. And then, as you'll remember in your registration, we have an open 30 minutes at the end that we're going to be using for questions. So as I mentioned earlier, please make sure to type your questions into the chat box and be sure that they're addressed to everyone. I think it might say all panelists and attendees, or it might say everyone, but just make sure that they're going to everyone so that we are able to save those at the end of today and that we make sure we see all of your questions. As time permits, I will ask your questions of the presenters during their portion of the agenda. But if we do run out and we kind of need to move to the next piece of the agenda, those questions will be saved for the final 30 minutes. And then any questions that we're not able to get to in the 30 minutes at the end, or if you're not able to join us for the last 30 minutes, we are going to do, as we always do at a community of practice, and make sure that all of those questions are captured and the answers are captured, and that we send out that written document and disseminate that hopefully within the next week or two. So rest assured, any questions that will be asked will be answered in some form at some time. We will do our absolute best there. So with that, we're on to our next slide, which is where I will introduce Dr. Molly Rosignol and Jim Potter, who are going to do the first portion of our agenda and discuss the regulations and laws and things like that. Molly and Jim, if you're able to or interested in turning on your video, please feel free to do that. I'm not sure if you're able to, but if you can, feel free, and I'll hand it over to you.
Thank you. This is Molly. Can you guys hear me? All right. Can I just ask Hannah when I need her to advance the slide? Is that what we're doing?
Yes, please do.
Perfect. Okay. Oh, turn on my video. Can you guys see me?
No, we can't see you.
Oh, I don't even have a video. It doesn't look like I have a video option.
Okay. Sorry about that. Never mind.
It's okay. I didn't put my...
Oh.
We're all learning this, but same system.
Let's see.
Oh, I guess I can put my video on.
All right, I'm going to, Molly, you start talking, and I'm going to move the presenters over into the panelist section, so then you guys can turn on your videos.
Perfect. Okay. All right. So we're going to be talking about, Jim and I are going to be talking about some of the regulations, which clearly this is becoming fast and furious. Next slide. All right. So objectives. I hope I hit all of these. It could be that I hit only a few, so I apologize for that. But certainly reviewing changes in care of patients with substance use disorders. I mean, we're facing, as physicians, facing changes in care all over the place. We're, not doing elective procedures. We're not doing routine care. Physical exams can be done over the phone. I mean, who knew that? But certainly in a setting where we're very used to seeing patients on a frequent basis, some patients coming in up to even twice a week for some practices, this is a significant change for us. We're going to look at the government regulations, both state and federal. Evaluating risks and benefits to shifting to telehealth and in the addiction space, and I certainly will defer to the other presenters for the most part on that. And then looking at the other factors that COVID-19 can influence in the health of a very vulnerable population. Next slide, please. So in all, looking at, we have two epidemics we're looking at. COVID-19 being a pandemic, kind of colliding with the substance use disorder epidemic. Age, we know, is a risk, and I certainly take care of some folks who are in their 70s with opioid use disorder, knowing that many of our patients may smoke or vape, and certainly that increases the risk for lung injury and susceptibility to the coronavirus complications. Stimulant use increases the risk for pulmonary hypertension in a obstructive vasculopathy. That's not exactly understood, but that is something to maybe discuss with patients. Our patients may have unstable housing, so maybe they're living with family members or friends, or sleeping on a couch now, or just don't know where they're going to be staying. That's a concern. And then homelessness can increase the risk that folks don't have access to soap or water or clean practices. And then, of course, self-quarantining would be nearly impossible in possibly even both of those settings. We have an incarcerated population, of whom many have substance use disorders, and therefore keeping social distancing can be a significant concern and problem. Food insecurity, and therefore nutritional and nutrition issues, and being able to stay healthy. We know that obesity also is a concern in the setting of this illness. Physical comorbidities, any who may have COPD issues, cardiovascular, obesity, as I mentioned, and then immunocompromised states, increasing potentially our patients' risk with exposure to coronavirus. And then, of course, we have at least 50 to 60% of substance use disorder patients with substance use disorders may have comorbidities with mental health. Next slide, please. So on the flip side, looking at from a setting of substance use disorders, what can go wrong in the setting of a pandemic? I think clearly there's a ton of anxiety out there anyway, and this is something that really could have a significant poor outcome for our folks. So certainly anxiety can trigger a potential relapse. I know if somebody is continuing to use or has lapses, clean needles could be harder to come by, even if they do have access to syringe service programs. Those syringe service programs have needed to change their regulations or change how they are servicing folks. A reduced ability to see prescribers. Certainly, if somebody calls my office, we are determining whether they need to come in or not. And that could be a concern for folks finding treatment. Concern for medication access. I've gotten calls from my patients being concerned that they may not have enough. Should they cut back on their medications now? Or should they expect to continue to be on the same dosing? Some programs that require counseling, our patients may be, in order to get medication, our patients may be deciding, do I go and expose myself in a group setting or go without medication? That could be a significant concern and cause somebody to potentially have a lapse or reduce their medication dosing as well. Regulations around prescribing. We have, I've gotten quite used to knowing I need to, I can call in medication, but I can only call in, up to a month at a time. And some patients are only getting 1 week at a time. And then we certainly have our DEA regulations that we need to maintain. The levels of care, if somebody needs, say, a residential level or an IOP, maybe they'd be concerned even to seek care because they don't want to be in a setting where there'd be multiple people and the increased risk of exposures. And then mutual help, if somebody has relied on that for a real long time, now suddenly AA, NA, other mutual help are no longer able to meet. Fortunately, we know that we have a significant and robust Zoom and other platform meetings, which I think at this time we probably all could use some supportive Zoom meetings myself. So next slide, please. So I wanted to just touch on one of the pieces of legislation that was, I think it was about to be heard. There was a hearing in the Senate for this. It was Senate Bill 647, it actually mirrors House Bill 1623. And so right now in the state of, in the state of New Hampshire, we follow the Ryan-Haidt Act, which basically says that for a first visit with a provider, it must be face-to-face before any a medication for substance use disorder or an opioid can be prescribed. And so this bill, the SB 647, was seeking to increase, the goal of it was to increase access to medication for opioid use disorder or MAT using telemedicine without a face-to-face first visit. And it essentially said it had 5 different places that if the patient is physically located in a specific site, and the 5 places are listed there. Monitoring would be via technology. There was a requirement for a follow-up in-person visit with a prescriber within the first year. And then it also mandated that Medicaid coverage of services via telemedicine would be required to be covered. So this did not, I don't have a video. Are you okay? Can you still hear me?
yes.
Okay, good. Sorry. This did not make it to the hearing. I mean, it was like the day before, before the state capitol kind of shut down and said nobody else, you know, they didn't want the legislators coming in and potentially putting themselves at risk for exposure. So this is still out there. It is likely that this is going to pass. So, you know, as we move forward, it's just really interesting because this is really a non-issue right now, as we'll see as we go forward. So next slide, please. This is, I'm sure, fairly familiar to folks. It's from the Johns Hopkins website in managing and monitoring the outbreak of coronavirus. What Jim and I are going to talk about, this is based on a temporary and emergency basis. And I put that there because, you know, perhaps things will change, and I suspect that Gus and David will touch base on that. But this is really to keep people healthy and contain the community spread of coronavirus. You know, that's really the purpose of these changes. And those agencies and organizations are listed there that we will touch on. Next slide, please. So lots of information here, but I wanted to put this on a timeline. Okay, because for me, it kind of, I'm a bit of a linear thinker, and it just was helpful. Things were coming out really, really fast. Before January 31st, though, you guys all remember when we could fly and we could go to Florida and stuff. So interestingly, as I was looking up the public health emergency declaration, which happened on January 31st, January 24th, Alex Azar proclaimed or declared that the opioid epidemic is still a public health emergency. And it was reissued, and it's been reissued quarterly since 2017. So, you know, if there is one thing that we could say, if we've made these changes based on a public health emergency, why have we not suggested changes based on the public health emergency of the opioid epidemic? But just very interesting. So January, that happened. On March 13th, President Trump declared a national emergency. I'm going to go over several of these. So this is just really just a timeline to document when things happened. Next slide, please. For those of you who work in an OTP or an opioid treatment program or methadone program, there was one of the first on March 16th, SAMHSA released this statement, and essentially is an opportunity for OTPs to give take-home methadone to their patients or their clients. Essentially, typically a person will visit a methadone clinic once a day for their treatment, for their medication. And it takes about 3 years of being in an OTP to receive a 28-day take home. So this is markedly, clearly representing the urgency of this pandemic and the real need to keep our patients safe and avoid interaction with other folks and social distancing. So the first one said, they can receive up to 28 days if they're real stable. And then the way I interpret the 14-day take home is, well, if they're pretty stable. So 28 and 14. I did contact our state opioid treatment authority, who really can determine whether he or she will allow the 28-day or 14. And his response to me was that he is following the recommendations of SAMHSA. So these are available, but I believe, and if there's anybody on the phone who is at an OTP at the end, please feel free to chime in, because I've heard from 2 OTPs that they are not going quite the limit of 28-day, that 14 is where they've decided that they will push that limit to. So, but anyway, this is one of the first guidelines. And then along with this, if somebody is being quarantined, if a patient needs to be quarantined or has symptoms or has COVID, they can make arrangements for the medication to be delivered to the home. So next slide, please. The next, I think this was on March 17th, the Office of Civil Rights talked about HIPAA, and essentially never would we be doing FaceTime with patients. That's totally not HIPAA compliant. However, we can do that with, as they call it, a discretion of in enforcement. And I like that term. Essentially, we shouldn't be expected to be prosecuted for violating that HIPAA rule. SAMHSA, now this is not saying that you can, we're just scrapping 42 CFR Part 2 if you are a provider for addiction care. Essentially it says if there's a medical emergency, we can forego getting written consent from the patient. And in an area, I was trying to think, well, when would that be? Perhaps somebody gets discharged from a residential facility and would like to hook up with an outpatient setting, but either did not sign a consent or found a place and they want information from the facility to send it over. So in that case, we can forego the 42 CFR in order to get somebody set up with proper treatment. It must be documented in the chart and must be, as they say, bona fide emergency. Next slide. All right, Jim, you're up.
So the emergency order number 8 from the governor really expands telehealth coverage, and it expands it. So essentially, you're paying at face-to-face rates what you are doing now for telehealth or telemedicine. It applies to all commercial or private carriers, the Medicaid and the Medicaid CMOs. The important thing to remember here is that it doesn't apply necessarily to the employer self-funded plans through ERISA. We're trying to chase that down. We're trying to get compliance, but there is that kind of entire soft underbelly that the ERISA plans could undermine the whole shooting works here. We'll continue to work on. Now, it applies to physicians, APRNs, and a wide variety of other practitioners are identified. There are no restrictions on the originating site, so you can do this from your home. One thing I would mention that goes back to the HIPAA compliance, when you are working with a patient, I would strongly suggest that you ask them to move into a private space. And you as a practitioner should probably also have something that gives you some semblance of privacy between the practitioner-patient relationship. Third, reimbursement. We're talking about a GT modifier. You have to notify the place of service, which is POS 2 for telehealth. Now, the reality here is not every payer does this the same way, and we're kind of just learning this right now. But we'll talk a little bit later about some reimbursement policies, but we'll also probably come out within the next week or so on some more specifics, because there will be some differences required by some of the private payers, Medicaid and Medicare. Please document this as you would a face-to-face delivery. And again, there's a number of modalities that you can use under this, including any kind of HIPAA compliant audiovisual two-way communication, audio only, which means telephone, FaceTime, Messenger, you can see the rest, Skype, those all can be used. What are not recommended and you should not use is the live, Facebook Live, Twitch, TikTok, or kind of some similar kind of public-facing video apps. The security on those is not, and you probably heard some of the horror stories about folks being interrupted by others who might have access to those mediums. The biggest thing I also want to put out is there's the Office of Professional Licensure.
Okay. Rika, did Jim just disappear for you too?
Yeah, it seems like maybe his internet connection or something
Dropped out. Okay.
dropped
Molly, are
out.
you able to pick up for Jim right now while we try to get him back on?
Yeah, so there was a question. I know that, and Jim knows this stuff much more eloquently than I can say, much more eloquently than I. But what happened was, yeah, I know, Polly. I want him to come back too. So what happened was there was a question. This came out the same exact day that the DEA came out and said, you guys can do first visits with audiovisual. That's fine for OUD. The governor said, you guys can do audio only if you want. And what was interpreted by one of our hospital systems was, that doesn't fly. You still need to see the person in person. And so it was really, there was, it was conflicting. We didn't know. And there's also a state law that said you have to do inpatient visits if you're going to be prescribing any opioid. So that lasted about 18 hours. We were struggling, what's going to happen. And Jim got in touch with the OPLC, who essentially said that the executive order overrides any state law conflicts. So that, fortunately, for our patients, gave us that opportunity to continue to keep them safe, protect them from being exposed, and carrying on with appropriate care. So. Is he on yet? Is he back? No. Next slide, please. So the DEA gives us guidance and responsibility. They have a responsibility, I'm sorry. They give us guidance, but they also have a responsibility. They are not a law. They're not the law. So it is important to keep it, to know what the federal law, what the state laws are. But certainly I'm a little afraid of the DEA. So telemedicine rules still must be a legitimate medical purpose, must be appropriately licensed personnel. We must have sufficient information from a patient, or do a proper exam and know that they are appropriate for treatment programs or for medication. And then we also have to comply with applicable state law. The responsibility of the DEA is that they ensure that the supply of controlled substances is adequate. So if you are concerned, you certainly can call a pharmacy to see if they have low supplies. But if we're worried about a national supply for, say, buprenorphine, checking the DEA websites, they will document if there are concerns around medication supplies. It's their responsibility. And then the DEA, interestingly though, determined based on the HHS the HHS public health emergency declaration, that now if you have a reciprocity license, so if you live in New Hampshire and have a license in Vermont, or even now we can go online and ask for a license in, say, Vermont, Maine, Massachusetts, to help out. We are not required to have a DEA in those states during this state of emergency. Otherwise, we would need to have that DEA if we wanted to prescribe for a patient in a different state. So, so that has also been waived.
Hi, Molly. Jim came back on his phone. It looks like his computer died, so I just turned on his phone audio. He should be able to come back.
Okay.
Sorry about that, Molly.
That's all right. Jim, I tried to explain about the OPLC.
Oh, thank you. Yes, the short answer to that is OPLC, we were having some problems with some lawyers in the health system who were taking out parts of state statutes and saying, well, no, you can't implement telemedicine because of these conflicts with state law. So the easy way around that was to get a guidance from OPLC that said, essentially the governor's executive order number 8 overrides any possible state conflicts. So if you run into issues like that from other sources, that's something you can point to. And as we'll say, anytime you have an issue, bring it to us, myself, or someone on my team, and we'll knock it down for you.
Thanks.
Okay, and I did go through the next slide, so let's do the next
Perfect.
slide. Jim, can you still see the slides or no?
I can.
Oh, you can't. You can or can't?
No, I can. I have that up, but you can't see me, so I'll just talk
Okay.
it. So really a couple areas here that are really to differentiate. So for an initial evaluation for a new patient, initially they said you could only use audiovisual two-way, real-time kind of two-way interactive telehealth systems. Then they later made a modification and said, no, you can also do it for audio only or a telephone. But this is really in your hands. You have to make sure that you feel that you're comfortable that an adequate evaluation can be accomplished and you're actually talking to the individual who has an OUD. However, the initial in-person evaluation is still required for methadone. Prescribing methadone. Second, for an ongoing evaluation, it can be essentially telephone or it can be an audiovisual telehealth system. Now, for Schedule 3 for a controlled substance, a qualified practitioner, you can submit a subscription either electronically if you have already a system set up. It can be via fax or a photo image via email. And if this is an emergency prescription, you can also do it by telephone. Although I will tell you, this seems to be an area of contention with a number of different pharmacies. And again, we're trying to get education out, and we're trying to get some sense of a common approach through the Board of Pharmacy, but that's still likely going to take a little bit more time. So I would just ask again, you'll see information at the end. If you have problems with a individual pharmacy, then please let us know. And the more specific, and even let us know the pharmacist you dealt with, the pharmacy where it's located, all that information gives us an opportunity to essentially, we're going to try to do this by education as much as possible, but we know that there's a lot of different interpretations. Individual pharmacy chains have also different interpretations on how they're looking at the DEA regulations and how that kind of comports with a state law. Next slide, please.
I'm not gonna, I think, I'll just comment. I know we only have a few minutes left, and I think that, that Gus and David will do a good job of kind of talking about implementing this. This is on the DEA website. I found it really helpful. It's just kind of a bubble path of, you know, how to determine caring for patients. So you can go next slide. Also, I think I will not belabor the point. This will be on, you'll have access to this, really just looking at what are the things I think about for whether my patient meets criteria for telehealth or not. I practice 1 day a week in Manchester, and I have had a couple of my patients come in each day based on their situation. So, but many have been telehealth. So go on, next, please. So, and then best practices for new patients. Again, I will defer to Gus and David. However, I want to say one of the things which I think they'll talk about it anyway. Next slide, please. I don't want to belabor the point. ASAM, David has brought to the attention, any of you have tuned into his Thursday meetings, brought to our attention ASAM guidance, which is really terrific. There is each one of these blocks opens up into many different resources and information. I think it's a great place to land to answer all kinds of questions in this space. Next slide. Jim, you're on.
So here are a couple of different scenarios that you can take, and I won't belabor these, but again, this is from a Medicare perspective. And this is going to be, each of the carriers are going to change a little bit. Again, we'll try to get out a guidance. We have produced, and we'll make sure that gets out, a telehealth, telemedicine reimbursement guide. So we'll make sure that that gets out to the host and they can send it to you for everyone who's participating today. But that kind of gives you real-time links for each of the major carriers in the state and where their policies are. Within the next week, we hope to have more of a spreadsheet so you can kind of go and look through. We're really trying to promote transparency in all these and make sure that that you're not getting some of these claims kicked back at you or denied. Again, the thrust of this and what we've been trying to emphasize to all the carriers is that we're really trying to promote continuity of access to care on that and safety. So we've gotten real good cooperation from most of the carriers, but again, if you have issues, then please bring them to us. And so either we can clarify that, help clarify them for you, or help them get corrected if it's a policy issue. Next slide, please. And then finally, the information here is, please write this down, even my mobile number, my email. We probably take on somewhere between 15, 20 specific phone calls on issues related to COVID-19 coverage policies per day. And we're happy to try to address any concerns that you or your practice have in getting care to OUD patients.
Thanks so much, Jim and Molly. Really great, rapid, but very comprehensive overview. Just a reminder to get those questions in on the chat so that we can address those at the last of our 30 minutes. We're gonna pass it over now onto the next slide to Dr. Crothers and Dr. DeGeisel. You both should be able to unmute yourselves and turn on your videos, so please feel free to do that. There's Dr. Crothers himself joining us from Maine, so I will hand it over to him now.
All right, great. Thanks so much, Adelaide. And thank you, Molly and Jim, for the overview. And thank you for the invite here. I'm not a New Hampshire local, but I'm nearby. I'm in Portland, Maine, where I live and practice. I'm the National Medical Director for Groups Recover Together. Some of you may be familiar with us. We have about 8 locations in New Hampshire, serving about 800, 900 members across the state. So obviously high volume, and have been doing this for a while, and had to switch over very rapidly about a month ago to a virtual practice model. So we've worked out a lot of the kinks. I'm not saying we have it perfectly, but my goal today, and I know the goal of Dr. DeGeisel as well, is to share with you as a colleague, what this looks like in practice, some of the barriers we've encountered, some of the ways we've gotten creative and overcome those, and hopefully help you feel more comfortable and ask questions. It's one thing to hear the regulations, but I feel personally as a provider, it's another thing to hear from your colleagues and actually feel like you're not the only person on the block practicing in this new way. So that's my goal today. I serve in New Hampshire. I'm mainly in an administrative role, helping to supervise our patients there, but I also care for 275 patients in Maine, and we're also in a virtual model in Maine as well. So very much living the things that I'm going to be talking about here. So the way Dr. DeGeisel and I are going to split this up is I'm going to spend a few minutes talking about best practices and tips and tricks for intake of new patients. Then I'm going to turn it over to Dr. DeGeisel to talk about established patients and ongoing care. So Hannah, if you can go to the next slide. All right, here we go. So this is the only slide I want to walk you through, just kind of take you through some of the points I've been thinking about as we developed our protocols for new patients. And I field escalations from our medical staff around the country. And these are the sort of things I sometimes get questions on. I'm getting more questions on in the last month. but as what we have worked through and is working well for our practice. Again, what we do is not the only way to do it, but I hope that it helps you feel more comfortable. So the first part, which I think is kind of the context that's coloring everything we're talking about today, is your own personal, individual, or practice philosophy and where it sits on the spectrum of harm reduction, as I like to say. This is something the whole industry kind of grapples with, all of us who treat substance use disorders. Some of us work in programs or practices that have a lot of structure. Other of us work in programs or practices with less structure. Frankly, some people call that structure, some people call that barriers. I'm not going to opine today on what's the best way to practice, and frankly, medicine is still a mixture of art and science, so at the end of the day, there is no right answer. But the point that I'm getting at here is that this crisis, I believe, no matter where you are on that spectrum, has forced all of us to move further towards harm reduction and probably eliminate or at least temporarily suspend some of the structure, maybe some of the rules or some of the barriers, or basically change the way that you've been doing things. It may seem obvious, but I thought it was important to come out and just say that, because frankly, a lot of the calls that I field from providers is just about that. Like, hey, Gus, we used to always do this. Is it really okay that we're putting this on hold for now? And the answer is yes. We have to weigh the risks and benefits of the rules and the structures that we have in place for good reason, but then also consider the more short-term risks that our patients may be facing due to the COVID crisis. So that's, again, I hope it's helpful to hear that from someone who's doing this every day, but each of you will have to make your own decisions based on the way you do your practice and the way your programs are set up. Next, on to some of the, just what I call the nuts and bolts, or the AV considerations about new patients. This is the not very exciting stuff, but answering these questions or figuring these things out can really make or break how things work. So, I think we're all aware of the various options we have for telehealth platforms. I'm not here to sell any one of them. Our personal practice uses RingCentral. We've found that it's supported us pretty well. Something to consider for your patients is whether or not they have to download any particular app or install any program on their computer or on their phone. If they do, we found that that's a barrier. We liked RingCentral because it's just a link and they can click to it. The other thing that we found is that about 85% of our members are able to join any of our appointments via video. So although we have the option for telephone, we found that most of our members do have smartphones and are able to join via video. But that point is important in that of those who join via video, over 95% of them are doing so via smartphone. So whatever solution you pick or your practice has, I would just assume that it's going to be used via a smartphone and not a computer. And if it's not comfortable in a smartphone, it's probably going to cause problems. The flip side of that is that, about 15% of our members, for various reasons, internet access, lack of data, whatever, are still kind of leaning on their telephone for access. So whatever platform you choose, it was really helpful for us as we were evaluating to make sure that it has a dial-in option. Not all platforms do. Zoom does, the one we use, RingCentral does, but having surveyed the landscape, not all of them do. So that's something important to consider. Another thing is consent forms. Obviously we've loosened HIPAA regulations, but 42 CFR does still apply, and a lot of its clauses and most of our programs have some requirement for consent forms in order to treat. We were very quickly able to put these online and send them for electronic signature. Again, if you have that smartphone and you can receive a link, then you can very easily receive a link to a cloud-based e-signature product. There's dozens of them that are out there. Many of which for free or sometimes require a small subscription fee, but things like Adobe, things like HelloSign, things like DocuSign. So really the need for pen and paper forms is almost outdated at this point. And we found that was something that was pretty easy to switch over to, just scanning our forms in and putting them online. Those were kind of the major things in terms of getting the platform set up and switched over. The other thing I was going to say that really will help you and your practice not pull your hair out is in this day and age, most folks prefer to communicate via text message rather than email. We found that especially with our patients, it's definitely the quickest and the fastest way to get their attention and get responses. And it really helps if you or your administrative staff have some way to send text messages via a computer. Because unless you feel like individually typing in all the hyperlinks or all the info you want to send out, it really helps to be able to cut and paste or have some sort of a platform that allows you to deliver a message text message out to many people. So our electronic medical record allows us to do that, but if your EMR does not, there are all sorts of other platforms you can download and use to send this out. So those are some of the things I wouldn't necessarily have thought of when we had to turn this program on, but that our helpful operations people kind of figured out very quickly, and I wanted to make sure to share with everyone. Moving forward, so talking about some of the clinical issues, hopefully this is review for most people, but I think it's just helpful again to hear it, that establishing the diagnosis of opioid use disorder really is done via history. If you look at the 11 criteria that the DSM-5 has, none of them requires a physical exam, none of them requires a urine drug test or a lab test. And so it's really something that you can do over the phone and taking your history. And really the onus is on understanding, is this person a reliable historian? And again, you don't need to be in person to make that determination. And if you're really struggling with their reliability, you can always try to get a confirmation from a third party, whether that's a relative or a friend or a prior treatment provider, et cetera. And all of that can be done over the phone or over video. The other point, exam, over the camera, you can do a COWS score. You can, the COWS score does require a pulse, but I've never met a patient who can't take their own pulse while I time for them. You can look for the presence of goosebumps or some of the other physical signs that's present in a COWS score, all via the camera if you have that set up. We so far have yet to come up with a situation where the camera hasn't supported the physical exam that we feel is required or is helpful and appropriate for our intake. Moving on to toxicology testing. So when we switched over rapidly, we put our toxicology testing on hold, but pretty quickly what we were able to do is for our new intakes, we actually overnight point of care urine drug screening equipment for them to do at home. So usually we're able to get that to them before their appointment. And if we can talk them through how to do it, they provide the specimen in the cup and they hold the results up to the camera or text us a picture for our staff to interpret. If we do and we found that that's worked quite well. If you don't have that, that resource available to you, or if you're just not set up to do that, we've also, or frankly, in our practice, if we get someone in for an intake same day or next day, we probably can't get them the toxicology testing yet. And again, it's a nice to have information, but it's not critically necessary for establishing that first diagnosis. And then ancillary testing like hepatitis C or LFTs, those, again, I view those as nice to haves with a new patient, but in this critical period, I think those can safely be delayed until the risk of COVID-19 reduces. Moving on to the last 2 points, prescriptions. If you're not already doing home inductions, this is a great time to start. There's a tremendous evidence base here and it's really convenient for the member. There's lots of resources for how to do home inductions online. The California Bridge program has a really great patient handout that I often use. I believe SAMHSA even has one now. So really, it's never been easier to get started with home inductions. And then the last point on behavioral health, my program specifically has behavioral health kind of integrated right into it, and we've switched that over to virtual. Your program may or may not have that. You may be making referrals, but I would just emphasize that I think having access to behavioral health as part of the overall treatment, I think has never been more important, just given the isolation, the disruption to routines, et cetera. And I think the other flip side of the coin is that there's never been more availability for getting behavioral health from home than there is right now. Both whether that's AA or NA or virtual support groups, or just a lot of the behavioral health practices out there that have very quickly adopted telemedicine. So I would just encourage you to continue making that a part of your initial recommendation with new patients and probably emphasize it more than ever now, given the challenges people are facing. I'll pause there. Hopefully those are some helpful tips, and I'll turn it over to Dr. de Geisel.
Hi, everyone. I'm David de Geisel. I'm the Medical Director for Better Life Partners. If you would advance to the next slide, that helps me guide my remaining minutes a little. Thank you. Wonderful. So I'm going to talk to you a little bit about our experience with telemedicine, and then more from the perspective of continuing care, as opposed to Gus's overview of how to enroll new people in care in the current setting. And you'll see the overview here. Let's see how far we get. We only have about 5 or 6 minutes left. So without rushing through it, I think we first we should realize that the way we provide care is mostly in group settings, where the majority of the groups or the meetings are run by counselors, and then our clinicians sit in on those meetings about once a month. And those group meetings, we thought would be quite challenging to run over a teleconference software like Zoom or any of the others. But I think similar to Gus, we were quite surprised how well that has worked for folks. So we also give people the ability, or we encourage them to use video, and most folks are able to do that. And then people who aren't are allowed or permitted to call in through the phone. And our attendance has been exceptional. In some cases, we've had better attendance than when we had physical meetings. And I think that's due to a couple of things. So one is, I think we can offer folks a little bit more flexibility. For example, if you for some reason can't make it to your usual meeting, then it's much easier to dial into one of the makeup meetings, right? We have meetings in several towns around New Hampshire, but you can imagine there are some towns where really there's only one meeting a week. Whereas now, if necessary, we can let you join a meeting that's a couple of towns further down the road. So I think that's one reason that there is some increased attendance, which I think is really a benefit to us having rolled out telemedicine so widely and so quickly because of the need to promote social distancing in this crisis. But I think it's an element that hopefully we can retain, at least in part, going forward once we don't have to be socially distanced anymore, but can choose to do so for certain people and certain settings. The other part I think that's come up that's interesting is that for folks who tended to be quiet in these meetings, oftentimes find it easier to participate over video or just a phone. And I don't know why exactly it is. We certainly haven't studied that, so I think it's mostly anecdotal, but I think the impression is that some people feel more comfortable not being in a room with people, maybe feel more comfortable being at home or in their car or wherever they are when they're participating in a meeting. I think if you want to put it in more sort of a medical social framework, I think it might be a more patient-centered or patient-owned experience rather than, you know, taking people out of their comfort into a medical setting, or well, many of our meetings actually not even run in a medical setting per se, but in a community location. But still, it's not your home, right? So here we're really meeting people where they are, literally in their own home environment. So I think that's brought on some really interesting interaction that I think many of our clients actually quite enjoy. Now, there is also a flip side to this new environment. And one thing I think is the privacy issue. So we very strongly encourage folks to, or actually require almost for folks to really be in a setting where they can maintain privacy. So for example, if you're dialing in for your weekly meeting, we ask you to not be in a room with other household members, not with your kids, not be in a public place. And that's partly because it can be disruptive to the meeting, but more importantly, that if you are in a public place or there are other folks around, then we can't maintain the privacy of the members in the group. And that's really, really important in general, and especially I think in in substance use treatment, where I think we really want to preserve the privacy and protect the anonymity of folks. So while we pay a lot of attention to that and encourage people, you can imagine that it's not always easy, right? I think we all should acknowledge that the folks we serve oftentimes don't have the luxury of being alone in a room because they live in very crowded settings and have kids and might not have childcare. So I think that's a point of tension. And if you're adopting similar technology in settings, I think that's something to be continuously aware of and try to help people really figure out how they can do their best to create an environment where they're fully dedicated to the meeting and can maintain the privacy. Now, dedication to the meeting or paying attention to the meeting, I think is another one that we probably all recognize, right? I think it's a very human behavior. Being on many Zoom calls these days, and I imagine that goes for all of you too, it's easy to do something on the screen while pretending to be in the Zoom call. And of course, in a meeting, that's not what we want. We want people to be really engaged. So again, something that we certainly don't police. We encourage people, we set very clear rules and give guidance at the beginning of the meeting. We do call people out when they're obviously not paying attention. In some regards, I don't think it's that different from in-person meetings, right? I think you've all probably been in group meetings and people have dozed off or clearly not been engaged. So again, I think it's too fresh and too anecdotal to say that this is really a huge difference to in-person meetings, but it's something to pay attention to, I think, right? So both the privacy and the level of engagement. And the third aspect I want to mention before I move on is the safety aspect. So while I think we're all aware that we shouldn't be on the phone while driving and certainly not be on a video Zoom call while driving, it still happens, okay? So operating machinery in general and driving a car specifically is not advisable when you're in a group meeting. And again, policing is difficult there, but again, something that you might want to pay attention to and really encourage people that it's fine to take a call from the car. I think that's for many people the most private place they can find, but please don't drive while you do that. So those are some of the group meeting experiences. I'm going to skip over the technology, although it's on my list there, because I think Gus very nicely addressed all of that already. And then with the 1 extra minute that I'm going to take from our schedule here, I just quickly want to mention a couple of things about buprenorphine prescriptions. So we have spaced out the frequency in which we prescribe. So typically we prescribe on a weekly basis, and we've now gone to prescribing 2 weeks at a time. We're constantly evaluating that. We made that decision very early on. I guess by now it's almost a month ago when we were headed into the lockdown, because we weren't sure how easy it was going to be for people to get to the pharmacy and what the pharmacy supply would look like. We also early on called around and involved all the pharmacies that we prescribed to check in with them. One, do they have enough on stock to double our prescriptions? And second, what was their expectation around supply going forward? So I would encourage you, if you're changing your practice pattern, do reach out to your local pharmacies to make sure that they can accommodate that. And now I would love to philosophize with you all about how recovery looks after the pandemic, but I think we're running out of time. So I'm just going to leave that there as a tantalizing thought. I think the way I view it is that I hope as a community, we can really figure out what this crisis has forced on us and what we have found to be beneficial for us as organizations and providers, and more importantly for our clients. And I imagine that we'll have to find some mix. We have to give up certain of these things again, and we should probably hold on and probably advocate very hard for some of these regulations to become permanent. That's all I got for you. Thank you so much.
Thank you so much, Dr. DeGeisel. I'm sure that some of these things are going to come up in our discussion. I just want to, Hannah, if you could go to the next slide, do a couple of housekeeping items in case there are some folks that need to drop off and aren't able to stay for our discussion. So the first is going to be, as I mentioned in the beginning, to utilize that Google group for questions, event resources sharing, and discussion about any of these things. We'll be sure to get the Q&A document out to folks that but also we'll probably share that through the Google group. So again, like I said, if you're not hooked up with that, please let me know so I can. We have a CEU and a CNE available 1 hour for this past hour. So in order to claim that, we are going to need you to complete an evaluation of this meeting, and we actually have a new evaluation process. Another perhaps silver lining of this whole thing is we figured out a really nice streamlined way to get you your certificates. So for tomorrow, look for an email that will have your electronic evaluation link in it, and then that link will take you to a page that will automatically give you your certificate in your email. So if you don't get that email tomorrow from me, Adelaide Murray, it probably means that I might have missed you in the attendance list. I couldn't recognize your name or something like that. So if you don't get an email from me by the end of the day tomorrow, please reach out and I will send you the evaluation link. On the next slide, I just have the meeting schedule for the upcoming communities of practice in case you have to jump off. We do hold these meetings every other month on the third Thursday at 2:30. As I said, they're typically in person, but until we know otherwise, they will be held remotely. So those were my housekeeping items. What I'm going to do now is give Reka a moment to give a little announcement that will kind of lead us into the discussion, and then we'll have that opportunity for discussion and questions.
Hi, everyone. I just wanted to take 20 seconds of your time to just let you know that the Center for Excellence will be offering a new time-limited opportunity related to prescribing and dispensing medications for opioid use disorder during the COVID-19 outbreak in New Hampshire. We're offering 50-minute sessions that will be held every Monday from 12:05 to 12:55, starting on April 20th. We've also convened an advisory team that is including Dr. Seddon Savage, Dr. Ruth James, and Dr. David DeGeisel. They'll all be participating on these sessions to help you answer your questions and to help you solve challenges that you're experiencing. So if you want an opportunity to talk through your questions and challenges, we're hoping that you will join us starting on April 20th. I will share the registration link through the chat right after this so that you can have an opportunity to register if you haven't seen the invitation that was sent out yesterday. In addition to that, we are looking for you to submit questions prior to each session. So if there are specific things that you either heard today that maybe isn't addressed during the remainder of our time, feel free to share it through the Google document that I'll share through the chat, as well as any specific challenges that you might want to talk through, as well as successful strategies that you've used over the last few weeks that you would like to share with others. Thanks.
Thanks, Rika. So Hannah, if you go to the next slide, we'll start our discussion. So the way that this will work, hopefully easiest, is if you are joining by computer and you're able to use the remote hand raise feature on Zoom, then I can click on you and open up your mic so that you can talk with us verbally. If you're joining just by phone, you should already have the ability to speak, so you can just say, excuse me, and talk that way. Or as always, you can chat your questions in, and Rika and I will read those and get them out to the group. So I'll give you kind of a minute to figure out that tech, formulate questions, and make sure that I'm seeing everything I'm supposed to see to help you all speak. Okay. So we have a question in the chat that I'll read out to our presenters. What are your thoughts on having patients go to outpatient labs during this time?
Yeah, I can speak for our practice. Essentially, we're putting it on pause for now. We're discussing and educating on the importance of hepatitis C screening and other primary care sort of screenings that require lab, but we're not actually writing those orders right now. We're noting it down to revisit when all this is passed.
Thanks, guys.
Yeah, I would second that. I'd be somewhat curious to mean what outpatient labs you're thinking of. Maybe, I mean, we're Better Life Partners is particularly, or is only prescribing buprenorphine for opioid use disorder, which doesn't really require many labs. So I'm with Gus, sort of screening for associated diseases doesn't seem to be so urgent, but maybe you're thinking of other labs that I'm missing.
So Dr. DeGeisel, Pamela responded and said, our hospital lab for our more at-risk patients, they're only doing Suboxone.
Yeah, again, I mean, I think for the buprenorphine, there's not really an indication to monitor labs, I would think. Now, if you have at-risk patients who have acute medical problems, I think if they reach out to you to address those, I mean, we really rely on a collaborative approach with other providers. So we then reach out to or help facilitate a connection to their primary care doc or to the hospital and figure out what's urgent, what's not urgent. But we don't take on those urgent medical issues ourselves, and therefore we wouldn't send people to the laboratory.
This is Molly. Because some of my patients actually do provide primary care services, simply because they don't go to primary care otherwise, and I'm a family doc, but some of them, for example, who may have alcohol use disorders, and I'm concerned regarding some medications that they're on. You know, it's sort of like who I decide to come into the office or not. And so some, I think, do need to go. You know, we need to be sure that we're monitoring, say, liver functions, not necessarily because they're on buprenorphine, but because there may be other mitigating factors that influence, you know, their health. So, but otherwise, I would agree with Gus and David.
Thanks, Molly. So Pam was just responding and saying that they're a primary care practice. So when she says at risk, she means unstable MAT patients. And then Gus shared the platform for the televisits. Thank you. So I'm making sure that I can see everybody if you do the electronic hand raise or write into the chat. Oops, sorry, everybody. It looks like, Gus, you sent that to the panelists, not to everybody. So I'm just going to copy what you said and send it to everybody.
We use Bring Central, those didn't hear it. It's not perfect, but it works for our needs.
Thanks. So we have a question that perhaps Molly will be able to answer out of CMC. So talking about the Manchester doorway and wondering what the status of the Manchester doorway taking over by CMC and Elliott is looking during COVID-19. Molly, maybe you can speak to, are the doorways still operating right now and kind of the status with that?
So the doorways are still operating, all of them, that as far as I know. The one in Manchester is not going to be taken over by CMC until May 11th. Tim Susi, who is kind of in charge of determining those strategies. But I think the idea is bringing the doorway in Manchester over to where Hope for New Hampshire recovery is, because that's where the CMC recovery program is. It's not where I practice, but I believe that that's where they're going to institute the doorway. But right now it is still under Granite Pathways as far as I know.
And still in the same location that it was in previously?
Yes.
Thank you. Just giving more time for typing and tech.
While we're waiting for somebody to jump in and ask a question, I will follow up with that. My understanding is that syringe service programs are available still as well. So I know that the one in Manchester is sort of a mobile. You could give them a call. You can check the New Hampshire Harm Reduction Coalition website, which will put you in touch with the various syringe service programs that are available. Just reminding folks to, you know, if they are at risk of using, it's even more important not to be sharing works or not to be sharing needles or any other equipment. So, you know, just putting a plug for further harm reduction and talking to our patients about that.
Molly, I had wanted to ask about something that you put on your slide that I don't think we got to, which was consider using oral fluid testing, perhaps in place of urine drug screening, or I might be reading your slides wrong, but could you speak more to that?
Yeah, so in the telemedicine arena, I know that, you know, Gus mentioned that sometimes they'll be overnighting for new patients the urine cups. Another option that I have, one of my colleagues who's in Maine, who's been using telemedicine for a long time, sends his patients oral fluid testing equipment. They do it while they're on the phone, so they actually, or while they're on audiovisual, so he actually can witness their taking the test, and then they send it back to him. There are oral fluid tests that are point of care as well. I've not used them other than, now that I think about it, I was tested at work to make sure that I'm not a smoker because they were looking for cotinine. But so there are oral fluid tests that are point of care. I'm not sure of their sensitivities and specificities, but that would be an option if you know, you wanted to look into it. I use oral fluid testing at my office, but they are sendaways. They're actually a hybrid, so they are using some confirmatory tests.
Thanks, Molly.
Yeah.
We've had a lot come in on the chat, mostly resource sharing, so I just want to let everyone know what's there. We have the website for the New Hampshire Harm Reduction Coalition shared by Dean Lemire, which lists all the statewide syringe service programs. Polly also shared the contact of someone named Ryan Fowler, who's the Harm Reduction Coalition at the HIV/HCV Resource Center at the Claremont Exchange, along with his phone number. And then I'll come back to that question in a second. I want to share what Amy shared, which is that all of the doorways are still operational and can be accessed through calling 211. Manchester and Nashua doorways are both open, and there will be a transition period to the new providers in both Manchester and Nashua during May and June, but the doorway.nh.gov has the most information there. So I'm going to go up to this question that says, have we been seeing an increased request for MAT since COVID? I've heard reports of decreased availability of fentanyl and other opioids during the pandemic and during social distancing. So wondering if patient counts are starting to increase due to that.
I can only speak for our practice, but we saw an initial decrease in intake calls, and now they've kind of come back to where they were before. So we haven't seen a volume spike, although we have anecdotally heard the same feedback from patients when you know, on our intake calls, but the numbers have kind of been what they were pre-COVID for our practice.
We've had a spike almost early on, possibly because we were one of the earlier ones to switch to tele and phone, and now it's sort of flattened out a little bit. But I think overall there's still an increase compared to pre-pandemic times for new enrollments. And then we've been very actively referring folks to the doorways for naloxone. Because I think, as Molly said, you know, a lot of the conversation that we have with folks is around harm reduction in the stressful times, and just acknowledging that relapse is a real possibility right now.
Dr. DeGeisel, you just segued me very well to the next question, wondering if providers are providing additional naloxone during this time, how they're getting access to it. Is there an adequate supply of that? Lindy's interested to hear from all folks on that.
I ask people all the time if they have naloxone, and I have not heard that there's any drop in supply. Again, going to the doorway, or Ryan Fowler actually put on a nice little a video the other day talking about caring for yourself in the COVID-19 times now, and he clearly stated that he still had naloxone to provide folks who needed it.
Thanks, Molly. Anyone else want to share anything about naloxone access? We've heard the doorways is a good spot to get it. Other ideas? So we had someone in the chat share that FASTER and other family support groups can be found on Granite Pathways nh.org, and many are still being held online using Zoom. So some more types of groups that are moving online, as Dr. DeGeisel was explaining. And then let me read this one. As the acute care healthcare settings focus on COVID and there may be limited access to inpatient withdrawal management, any thoughts or considerations for patients who may be experiencing withdrawal from alcohol or benzodiazepines?
So a couple of thoughts regarding that. I mean, even in the setting of COVID-19, if somebody is at risk for severe withdrawal from alcohol, we still need to make that determination based, if they have such a severe risk, and they are, and they have if they have withdrawal risk, they may need to be hospitalized. I mean, that needs to be acknowledged. That said, I will say the ACM is coming out with, I think it's supposed to come out, I think in May or June, sort of a guideline to alcohol withdrawal, which I don't think anybody wanted to, put their big toe into that, but they are going to be coming out with that because we do know a lot more about in terms of the number of people who are at risk for significant withdrawal symptoms. We probably overtreat and hospitalize too many people for alcohol withdrawal, and there are safer strategies to do it outpatient. And then there's those patients who aren't going to go to the hospital anyway, even if you tell them to. So it's sort of your hands are tied sometimes. So I think it's really important to do an evaluation based on somebody's risk. And if somebody is not going to go to the hospital, the other thing that I typically do if I'm going to do an outpatient withdrawal management is that I want to be able to see the patient every day. So then that comes into, brings in, do I do that via telemedicine? Do I actually have them come into the office? So there's still some pretty difficult things around alcohol withdrawal. And the last thing I'll say is, in regards to this is there was some ruckus about, well, why are we keeping the liquor stores open? And well, first of all, I think people are at home and probably there is an increase in number of folks who are drinking, and that actually, should not go without saying. And we do need to be aware that other patients in our practice may have an increased risk for binge drinking and complications from that. But at the same time, we don't want people to be cut off from alcohol if they have a high risk for withdrawal. So it's that balance of, if a certain substance is suddenly not available, that could increase the risk of hospitalizations.
Yeah, I really agree with you there, Molly. I think, the way I think about many of these issues about labs and, what to do with management of alcohol with benzo withdrawal, I feel this is an opportunity to indeed revisit some of the old standards that we set. And Molly, you're right? There's a good example that you can help people through alcohol and benzo detox at home. But you have to be comfortable doing that. And ideally, you have to have some experience doing that. So I don't think this is the time to practice cowboy medicine and do stuff that really is outside your comfort zone and that doesn't seem safe. However, if you can collaborate with people, or if you have experience doing some things that in pre-pandemic times you might not have done just because you work in a system that doesn't accommodate that easily, then I think it's fine to do that now. But otherwise, I would still very much rely on the traditional healthcare system. Mind you, one of the reasons that we wanted to flatten the curve is to preserve room in the traditional healthcare system to take care of all these other issues, not just COVID, right? And that was always the fear that if we exceed the capacity of our healthcare system through COVID, that people who withdraw from alcohol, who get into a traffic accident, or who overdose cannot get adequate care anymore, and that we would increase mortality and morbidity from non-COVID related illnesses. And I think as a state, we've done well flattening the curve, and we should therefore use the capacity that the healthcare system has to address these other issues, these chronic health issues or acute issues like benzo or alcohol withdrawal. So I think it's about finding that sweet spot, sort of what can you do? What are you maybe empowered to do right now because you want to keep people safe and don't want to burden the health system and want to not people expose and promote social distancing? But on the other hand, when does it feel right to provide adequate standard of care, which sometimes requires hospitalization?
Thank you. We have time for a few more questions, so I'll go back to looking for hands or chats. And as a reminder, if you did join by phone only, you should have the ability to just talk if you can't raise your hand or chat in. And then just, sorry, one more reminder that if you are chatting in, make sure that it's going to all panelists and attendees so that I can see it. If you're sending it somewhere else, I will miss it.
I'll just add, this is Jim Potter, add that we've sent to Adeline a couple links to two guides that we've developed. One is a telemedicine reimbursement guide. It'll take you through all the different payers and the issues that you run into. The second, as Gus kind of alluded to, there's a wide variety of vendors. So we've also produced a telemedicine vendor options guide. I think there's probably a dozen or more, dozen to 15 options there, plus a little bit of a checklist on if you're thinking about a system, what are some of those considerations?
Thanks, Jim. We have a question about wondering if there are technical resources or best practices that could help patients that are either less familiar with telehealth technology or those that don't have access to it. Maybe they don't have a computer or a smartphone or Wi-Fi or any of those things. What should we be doing with that?
I can just share anecdotally what we've done. We found that for patients who really struggled with Ring Central, our app, which we thought was pretty easy, Google Hangouts was even easier and came preloaded on most, but Android is the most common phone platform out there in America. And if you have an Android phone, you automatically have Hangouts already installed. You don't have to download anything. So that we've kind of used that as our backup. And in this short-term period, it's, it doesn't need to be HIPAA compliant, and we've had success with that. We've also had success just leveraging family members and friends to help them get set up and then, step out. Those are just two ideas.
Their thoughts there.
We some of our community partners are still operating, and they can offer people a phone line. So, for example, I actually don't know what the very current status is, but for a while, one of the food pantries in Manchester had a phone available for clients to call in. So that was another way that we could provide access.
Thank you.
I'll just say one more thing. Some of the Medicaid programs are doing their best to offer people cell phones. I know for the organization that I work for, we were actually having a hard time buying phones. We're doing our best, but we were like limited to buy 2 phones at a time from Walmart, but people were going multiple times to buy phones for folks.
Thanks, Molly. We have a few more questions that have come in. The first one being, what are people doing with their patients that are on Vivitrol?
I'm having patients come in and get shots.
And David and Gus, you don't have any patients on Vivitrol, is that correct?
No, but I would support that as well.
Although, no, it would be a nice trial to see if people can self-inject at home. But
David, have you ever given one of those shots?
Pardon me?
Have you given one of those shots?
No, I haven't actually. That's not something nice to do. Is that right?
Just watch a YouTube video.
Okay, all right. I take from your reaction that it's not advisable.
You have to be a bit of a chemist.
Okay.
Oh.
Well, I would say many of my patients and clients are quite the chemists, you know.
Wondering if people are aware of organizations in New Hampshire that are continuing or developing mobile pop-up, hold on, something else came in, so I lost it. Mobile pop-up or on-foot outreach for OUD med intake facilitation. So maybe speaking to the point that was brought up earlier, that there's more folks out there that this could be useful to, but how do we let them know where we are? Are people aware of any efforts that are happening?
I guess, Dean, thanks for that question. I actually saw that on your Facebook post a couple of nights ago, and I think that one of the things that I know that the fact that Gus and David, have programs, and there are others have programs that can do phone intakes too. I guess that's where we're starting. But there are programs out there in other states that have started outreach just like you're describing. So I appreciate the thoughtfulness and sort of the innovative thoughts, because that's perhaps where we need to continue to go to.
Yeah, and I can add to that. So, this is not as part of Better Life Partners, but in my other work, we have thought about doing this in a trial setting. So, would there, in a time of crisis like this, would there be a benefit to actively reach out to folks who previously were not ready to engage in recovery, and proactively offer buprenorphine? It felt that really would have to be studied, because, well, you can imagine there are it's a complicated concept, I think. And we haven't moved on that yet, but that's certainly something that we've been discussing. Yeah.
I can't hear anybody.
I can still hear you.
Oh, okay.
Oh,
Was that a line I couldn't hear?
Oh, sorry, I was muted. Well, I was just telling them about you, and now you're here, so.
Oh, so I guess my last question is, on the state level, is there, I know that there's the governor has an advisory board of substance use clinicians and people in the community, but what's being done with that as far as the COVID thing? I know there's been a lot of focus on various things. I just was wondering, on the state level, how are they keeping patients with substance use or residents with substance use in mind? I didn't know if anybody was involved in that, or yeah.
Well, I can probably try a stab at that. I will tell you, it's extremely fluid condition right now, working through issues on a day-by-day basis. There are a series of issues we've been working on for the last month that might have been announced today in one of the press conferences. So in particular, to individuals with OUDs, I think we try to make sure, if there are issues that come up in particular, or a problem, bring them forward. If they need some kind of specific response, then there's a series of state agencies that we try to work with to resolve those. Sometimes they can be done on an informal policy basis with some communications to practitioners or providers. Other times it takes more of a emergency order from the government when there either isn't clear direction, there's conflicting policy direction from both the state and federal level. So I guess the bottom line is, if you have issues or problems, just please bring them forward. And we try to aggressively, vet those issues out and move them forward to or where we think they can get appropriate action.
Thanks, Jim. So we
Maybe I'll
are.
just add a quick plug sort of for the long run. I know we're in the midst of this crisis, so it might be a little premature, but we've started talking, before the pandemic hit, we had taken the first steps to work towards a hepatitis C elimination effort in New Hampshire and surrounding states, which would very much focus on folks with substance use. And in order to pick that work up again, we've now started thinking about how we can integrate that with a Sentinel network for COVID. Because to let go of the lockdown, we will have to find a community-based way of making COVID testing very easily accessible so that we can find hotspots. And I think one could integrate that with, for example, a Hep C elimination effort and really focus on community-based healthcare again.
Thank you. So I'm just going to point out one more thing that was shared in the chat, and then we'll close out because we are at 4. Dean had shared that he had given us a little bit of a leading question that he is part of such an effort looking to do some outreach for folks that may be in need of MAT right now, and he's looking to collaborate with other groups, and that he shared us a great resource for COVID-specific safety guidelines for orgs that are willing to continue or begin such outreach services. So that resource and all the other links and good resources that were shared in the chat, as I mentioned, we're going to save that down. It'll get incorporated into the Q&A document. As I close out now, I am just going to leave the Zoom open for a few more minutes in case you had any questions that you needed to chat in and you didn't have a chance to. I'll leave the Zoom open so you can chat those in before you log off. And then, as I said, I'll get those questions back to the presenters and put that in the Q&A document. So with that, we will close out today. Remember to look for your evaluation and let me know if you do not receive it tomorrow. And thank you, everyone. Thank you very much to our presenters for pulling this meeting together on very short notice, and everyone for taking part in our first remote community of practice. So thank you, everyone. Have a great day.
Thanks, Adelaide.
Thank you. All be well.
Bye-bye. Happy Easter.
Take care, everyone.
Thank you. Hannah and Rika, if you could stay on for just a minute to make sure that we get everything.